So last topic of this critical care and anesthesia. So tracheostomy. What are the types of surgical airways? There are three: needle cricothyroidotomy, surgical cricothyroidotomy, and tracheostomy. What? How is jet insufflation of oxygen performed, and what is the main precaution to be considered? A large bore intravenous cannula is entered in the trachea through the cricothyroid membrane ligament. It is connected by a source of oxygen by a tracheal tube connector. The patient receives oxygen for 1 second and expires for 4 seconds. The patient is well oxygenated but poor ventilated. In consequence, the heat should be limited to 45 minutes period to allow the time for definitive airway to be established. What are the indications for tracheostomy? So again, a very common question, but when you start answering, you can't. So airway obstruction due to trauma of face, neck, or elective ENT surgeries, failed intubation by anesthetist, respiratory insufficiency, trauma to the larynx, inflammatory condition of pharynx, larynx causing the airway blockage, and long-term management of the ventilated patient, which is most common, failed extubation in extensive care, and the chest injury, flail chest, and congenital laryngeal or tracheal anomalies, and bilateral vocal cord paralysis. What are the types of tracheostomy? So percutaneous, mini tracheostomies, temporary and permanent. So percutaneous tracheostomies, these can be done in intensive care unit. They use a 14 gauge cannula with guide wire. After dilatation, dilators, they put the percutaneous tracheostomy tube. The advantages are less hemorrhage and infection. Mini tracheostomy, small tracheostomy tube is placed through the cricothyroid membrane and aid bronchial toileting and aspiration of the secretions. This is not a definitive airway because the tube is not cuffed. How would you perform a tracheostomy? So for elective operation, extend supine position with neck extended, under general anesthesia, intubation, 2 cm transverse incision, deepen the incision, extend between the strap muscles, retract or divide the thyroid isthmus, recheck size of the cuff tube to be placed, feel for the first tracheal ring, make a vertical incision through second and third ring, and anesthetist should be asked to withdraw the tube above the incision and be ready to change the ventilator to the tracheostomy, and then withdraw the endotracheal tube, aspirate the trachea. Insert tracheal dilator or cuff tube to secure the airway. Close your skin edges up closely and tape to secure the tape. How would you manage a tracheostomy post-operatively? Very important. So we need suction, humidified air, nurse upright, check breath sound on both sides, ventilator setting and tidal volumes, confirm with the chest x-ray, mucolytic agent sometimes used, and monitor for bleeding and tracheostomy cuff tube. What are the potential complications performing tracheostomy? Early, late, and immediate. Early and late. Immediate, patient can have asphyxia, patient can have esophageal injury, patient can have bleeding, patient can have pneumothorax or cricoid cartilage injury. And early aspiration, obstruction, cellulitis, tracheitis, mucus plugging, malposition tube, creation of a false track, and subcutaneous emphysema. Late, delayed hemorrhage, usually secondary to tracheonominate fistula, occurs more than 48 hours post-operatively. Vocal fold palsy, atelectasis and bronchopneumonia, tracheocutaneous and tracheoesophageal fistula, subglottic stenosis, tracheomalacia and tracheal stenosis, and difficult decannulation. Which anatomical structure is at high risk of damage when a tracheostomy is performed on a child? The innominate vein is at risk because it lies high on the trachea. Thank you.